Hi, my name is Tony Wilkinson, consultant podiatric surgeon and specialist in reconstructive foot and ankle surgery. Now today, the 12th of October, is World Arthritis Day, so I thought I would speak to you a little bit about some of the common arthritic problems that we see within the foot. Now there are a number of areas in the foot because there are a lot of bones in the foot, 26 in fact, that can develop osteoarthritis. And when we're talking about arthritis, what we're talking about is wear and tear arthritis. And that's where the joint starts to wear out, you lose the cartilage surface, and you end up with bone rubbing against bone. And that creates increasing pain, restricts walking and sporting activities. And there's absolutely no need for you as a patient to put up with these sort of symptoms. Now, one of the most common areas that we find is affected by arthritis is the big toe joint. And essentially, you get wear and tear between the base of the proximal phalanx within the toe and the metatarsal itself, the long bone within the foot. Another common area for arthritis is the second metatarsophalangeal joint. Now, usually girls about the age of 14 develop something called a Freiberg's disease, and that's where there's an interruption to the blood supply, and that can lead long-term to a collapse of the metatarsal head and long-term osteoarthritis. Now, if caught early, it can be saved, but if it's left too long, the joint completely collapses and wears out. Moving back into the midfoot, another common area is the second and third metatarsal cuneiform joints, otherwise known as the tarsal metatarsal joints. And these joints are usually associated with a condition known as hallux valgus or bunions, where the first metatarsal splays away from the foot, and as a consequence you start to develop pressure along the line of the metatarsal, and that causes wear and tear within the joint. Moving back into the foot, we've got the talar navicular joint, the bone between the ankle bone here and the navicular, the bolt-shaped bone, and that often can be worn out. Again, that can be affected by a condition known as avascular necrosis, where you get an interruption of blood supply to the navicular bone, and that starts to collapse on itself and leads to a wear and tear arthritis. And then finally, the subtalar joint, which lies underneath the ankle joint, is a common place where you end up with pain that feels like it's in the ankle, but is actually below the tip of the long bone in the leg known as the fibula. And usually if you find the point of the fibula and press underneath it, that's the subtalar joint. So let me take you to some x-rays and show you what these look like. So this x-ray is showing arthritis affecting the big toe joint, or the first metatarsal phalangeal joint. So when you look at the joint, it just looks like the joint space is missing. If you compare it with the joints over here, you can see there's a nice even joint space. The bone looks nice and smooth, and there are no kind of spiky bits off the side. Now, there are four things that we see with osteoarthritis. The first is that we get a loss of the joint space, so there's narrowing between the two bones. The second thing is we get the spiky bone known as the osteophytes, which develop around the margins of the joint. And if you look at a lateral view x-ray, you can see that there's a spike on top, looks like a little devil's horn sitting on the top of the joint. The next thing we see is an increase in bone density. This is known as subchondral sclerosis. Now, there is a natural sclerotic plate at the base of the joint, but this is increasing density as you get the wear and tear effect of the joint. And then finally, we get cystic changes within the joint. And if we just zoom in, we can see that there are small lucent areas here, so loss of bone density, which are subchondral cystic changes. Now, the big problem that patients are affected with is both loss of motion and pain within the joint. And we grade this in 3 stages. So grade 1 is where patients get pain, but there's not a lot of radiographic changes. Grade 2 is where we start to see some joint space narrowing and changes on x-ray with increasing pain. And grade 3 is where the joint has become more or less obliterated. And this is what we're seeing on this x-ray. The earlier stages of the condition, whilst we can usually save the joint, when it gets to the end stage, then we typically do what we call a fusion or arthrodesis of the big toe joint. And this is exactly what has been done in this case. Now, modern technology has allowed us to ambulate these patients quite quickly following the surgery. So whereas years ago you had to be in a cast and protect the foot for 6 to 8 weeks, these modern locking plates allow us to get the patient weight bearing from day one we ask the patients to rest for around 2 weeks, but then they can gradually get back into trainers and start ambulating on the foot and moving around. The idea of the operation is to lock down the joint so it doesn't move. So you have to be a little bit careful in the first 6 weeks because you don't want to overcome that fixation and cause problems. But this goes on to fuse, and whilst you're left with a stiff big toe, you do end up with movement through the joint next to it, and patients can usually do most of their activities without discomfort. Now, one of the biggest questions we get asked from ladies is whether they'll ever be able to wear a high heel again. And there's a little bit of an urban myth with this, because having your big toe fused doesn't prevent you from wearing a heeled shoe, although it does restrict the height of the heel. So certainly anything up to around 2 inches is usually fine, because actually you don't bend the big toe that much to actually get into a 2-inch heel. So the next condition we're going to talk about is the second metatarsophalangeal joint. And this is probably a post-Freiberg's disease. This is a female patient who's now 49 years old, but does recall a history of pain when she was around 14. And you can see actually here that the second metatarsal is slightly shorter than the first and the third. Normally the second metatarsal is the longest bone in the foot. And because there's been collapse of the joint, the metatarsal itself is shortened. The hallmark sign of this condition is flattening of the metatarsal head. So if you compare it with the next door metatarsals, they're nice and round, and this is flattened. And if you look carefully, you can actually see there is increased bone density just here. This is the sclerosis that occurs. You don't get too much of it on the phalanx like we saw in the last case, but the metatarsal head itself is affected. Now, when we look at the medial oblique view, we can see that most of the damage is around the top part of the joint, and the bottom part of the joint still looks quite round. So we can use this to our advantage. What we'd like to do is reconstruct this by taking a little wedge of bone out of here and closing the metatarsal space down to rotate the good cartilage from the bottom to the top. Now, the one sacrifice we make is that we do still have a little bit of loss of met length, and we have to always advise the patient that there is a risk of pain under the third metatarsal head, because what we do know as specialists is that when you disrupt the metatarsal parabola, the natural curvature of the metatarsals, you can get pressure load to an adjacent joint, which can cause problems. Now, the real dilemma here is whether we prophylactically treat this third metatarsal, but any metatarsal osteotomy or treatment is not without risk. So now the good news is this patient did extremely well. You can see here that there's a plate over the metatarsal where we've taken the wedge out. We've not lost too much length actually. If you compare that with a previous x-ray, there isn't that much difference in length. So there's little risk in transferring the problem to the third metatarsal head. But if that ever did occur, then we could do a simple shortening osteotomy to realign that metatarsal parabola. This next case is a patient who had pain in the middle part of the foot, in the metatarsal cuneiform joint, or tarsal metatarsal joints as they're known. And these usually affect areas just here. Often patients will notice a bump in the middle of the foot, which can be mistaken for a ganglion. Sometimes it is associated with a ganglion as fluid leaks from the joint and forms a soft tissue sac over the top of the foot. It can be difficult on x-ray to see exactly what you're dealing with. Here we have two views, a dorsoplantar view which is looking directly down at the foot, and a medial oblique view which is looking from a side view. We also have a lateral view here. Now the key thing is identifying the joints. So here we have the first metatarsal cuneiform joint. Here we have the naviculo-cuneiform joint, because this is a cuneiform, this square bone, this is a navicular. And then in the middle, which is superimposed, we have the second metatarsal cuneiform joint. Now, if you look closely and follow the skin contour, you can see that the skin bumps up at that point, and that's very much associated with these little spikes of bone over the middle part of the foot, known as osteophytes. Now, often when we're dealing with the midfoot, we have to order a special test known as a CT scan, because x-rays don't give us a full picture of what's truly going on. And a CT scan allows us to look inside the joints and slice through the foot, rather than just looking at a picture of the outside of the foot. So this is a CT scan of the patient we just looked at, and here we can see the metatarsal, the first metatarsal. We've got the square-shaped cuneiform joint just here, and the navicular sitting behind us. So we've got the first metatarsal cuneiform joint, the navicular cuneiform joint sitting here. We can just make out the leg bone and just make out the heel bone. As we start to slice through the foot, more bones come into view, and we can see that we now start to get onto the second metatarsal and the second metatarsal cuneiform joint. And just look at the amount of disease that is present within this. This is the intermediate cuneiform articulating with the base of the metatarsal, and we can see that there's a huge gap. It looks like there's bone missing, and this is the subchondral cyst that we were talking about earlier. As you start to move forward, you can see small cysts. You can see that the joint's starting to narrow off at the base, and you've got bone rubbing against bone. And as we slice through, we can see now that the third joint is starting to come into view. And we've also got a cystic change just there, which is quite significant. So this patient had a diagnosis of second and third metatarsal cuneiform joint arthritis. So this patient went on to have a fusion of the second and third metatarsal cuneiform joints. And again, we use these special locking plates that hold the bone together to prevent any problems with bone healing. Now, usually the patient does need to have some sort of brace on the foot. So the first 2 weeks, we usually use a small slipper cast, which is basically a hard bandage over the operative site. And then we transfer the patient into a removable air cast, which allows them to walk around without too many problems. Now, the problem we've got with these joints is there's a real jigsaw of bones in this area, and it can be very hard to push the bones together, because what we want with a fusion is to be able to join bones together. So we tend to use a little bone graft known as a dowel graft. And what we do is take an apple corer and take a dowel section of bone from the center of the joint, and then we take a slightly bigger dowel of bone from the heel bone and transfer it. So we've got nice healthy bone replacing diseased bone, and then we simply plate it to give stability. 6 to 8 weeks and the patient should be more or less back to normal. Now, as we move back into the hind foot, we get more problems with the joints that articulate with the ankle bone. Now, the ankle bone is this bone here known as the talus, and this is 75% joint. So it has a joint with the ankle, it has a joint in front with the navicular, and it has a joint underneath with the calcaneus or the heel bone. Now, this patient is suffering mainly from osteoarthritis, wear and tear arthritis of the talo-navicular joint, so the joint between the talus and the navicular. And again, we can see those hallmark signs of osteoarthritis. We've got narrowing of the joint space, we've got cystic change underneath the joint surface, we've got that density, that subchondral sclerosis, the whitening of the joint, and we've got those spikes of bone known as osteophytes. When we look at the oblique view, we can see that there is still some joint space, but it is very, very sclerotic, and the joint space is narrowed. When we look at the top view, the dorsoplantar view, we can see there's some alignment problems. And actually, this patient not only had arthritis in that joint, but he had a foot that twisted inwards, which caused pain along the tendons on the outside of his foot. So in this patient's case, we needed to do a double procedure. First of all, we needed to fuse the arthritic joint, the talonavicular joint, and then we need to move his heel bone, and we moved that laterally. So we moved the center of the heel to the outside of the foot to stop his foot from turning inwards. A bit like when you go over on your ankle, your foot rolls inwards. We wanted to try and stop that happening. So we did an osteotomy of the bone, moved it by 10 millimeters, and then fixed it in its new position with these small screws. Now, this takes a little bit more to get over than your average forefoot fusion. So the first 2 weeks we'll keep the patient non-weight bearing in a back slab, which is a half cast to allow for some swelling. And then we'll transfer them into the removable air cast, but we'll ask them to have limited weight bearing for around 6 to 8 weeks following the surgery. Once we're confident that everything is fused into place, then we can allow the patient to ambulate freely. When we look at the top view, we can see here that we've realigned the joints and fused these two bones together quite nicely using these very specialized plates, which usually stay there forever without too many problems. Now, finally, we have arthritis here of the subtalar joint. So again, we're looking at the ankle bone, the talus bone, and this articulates with the heel bone just here, and this is known as the subtalar joint. We've got the hallmark signs of increased sclerosis. We've also got these spikes of bone on the back, where we've got wear and tear of the back end of the joint. And again, the only real treatment for this condition is to fuse that joint. Now again, the CT scan is invaluable in diagnosing this condition, and we can see here we've got the fibular bone, the outside leg bone. We can just start to see the tibia coming into play here, and as we move through we can see the subtalar joint, and again we've got huge cystic change underneath, narrowing of the joint space with bone touching bone, and complete wear and tear of that joint. If we look at a different view, we start to see changes around this joint just here. So our only solution really is to fuse that joint. A fusion is quite a simple operation in this joint. We just need to remove the joint surfaces to make the bone raw so that bone grows into bone, and then we fix it with a screw that will usually sit there forever. Occasionally patients can develop pain around the head of the screw, so in a lot of cases now we use what we call headless screws, which are completely buried into the bone to prevent that from happening. But if patients do develop problems around the head of the screw, it's very, very easy to remove that screw because it's only needed while the bone is healing. Once the bone is fused together, it becomes surplus and can easily be removed. And that's the same for all of these fusion procedures. So I hope you found this video helpful today, and please remember, don't suffer with osteoarthritis. There are many things we can do, from simple orthotic treatment through to injections through to surgery. But if you do have problems, remember, call a foot surgery expert.